Hi.
You just got in. Oh, okay, you got in.
The issue is that it's letting me in as a viewer, not as a presenter. So I don't have the ability to share slides. But the little.
Not that I can see you.
Yeah.
So if you're a viewer, well, see, the thing is that it shouldn't let you, if you're just a viewer, it wouldn't let you in. So you're seeing, okay, so let's see.
Oh, it wouldn't?
Yeah, so you're more in than you are. Because I thought,
Oh,
no, you're more in than you think you are.
I'm going to hang up with you because I can hear you.
All right, let's.
You know what? And it now took off. It took
Yeah.
off the X over my screening.
Yeah.
So
There is a line over
Yep.
your screen. That's normal. I mean,
Oh.
that's normal. No,
Okay.
there's always. No, you're fine.
Can you see my slides now?
Yeah. Because I was like, if you weren't allowed in, I wouldn't be able to see you.
Okay.
So right, I wouldn't be able to see you like this. Yeah.
And you
so
can hear me okay?
I can hear you. And then the speakers can just, the speakers, did you take your thing away?
I did. And I'm going to try playing
So I was like,
video because we'll be playing a couple of videos. And I just want you to check the sound for me if you don't mind.
Yeah, I don't know how that's going to work.
Yeah.
We might need help with that.
Sure. No, I looked at it and
meaning just the platform. I'm not worried because I don't hear this.
Yeah, I'm going to play it now.
I want to get high. I want to feel
okay.
I want to be sick. I don't want to hurt. And a lot of times people will do anything at all costs to stop the hurting.
Can you hear the video?
I can.
Oh, perfect. We're good.
That's amazing. Now, just because it works this time, we'll just know that if it doesn't work, we'll have to see. But I'm not always convinced technology works the same every time you use it.
No problem. I did look at it. Was very good. I'm sorry I wasn't able to attend the tutorial, but I did print. I mean, I've got it all like printed. And
no, it's fine. Oh no, you're fine. You're good. So you're good. No,
But thank you for letting me test it because one thing is me doing what the instructions.
I agree.
Say, and if it actually works.
No. I don't even have the same, meaning like until I could get in, I couldn't test it myself. Like I couldn't do anything.
Exactly.
So, and that made me nuts.
Is I am going to try to log in again. I don't know if I'm allowed to log in as myself on 2 different devices. Do you know that answer to that?
I have done that.
Oh, I'm going to do that. So Dr. Suda is supposed to be coming over here, but we're trying to social distance. So we would have to be sitting side by side to kind of co-present if we're on one device. If I can get this on another device, I can have him in a separate room.
But he should be able to log in himself.
So I manage most of Dr. Suda's tech stuff. And I don't think we ever signed him up as a...
I did.
Oh, you did? So he's never gone in there.
Yeah, that's fine. But I did. I did sign him up.
Oh, fantastic.
The only thing is I don't know if it'll let you do video twice under yourself.
Well, maybe I can try logging in under. So it would be, did you do the Suda Russell at Gmail or did you do his Cabarrus Health?
I got to look. I actually have no, I kind of probably did.
I can try it right now. I'll just try both.
Yeah. But the only thing I'd be worried about is you can't share twice.
Right.
That might, you see what I'm saying?
Absolutely.
It might go, oh no, you're already there and you can't do anymore. I don't, or who knows what we'll do, but I'm almost positive I registered him. And actually, even if I didn't, I can do it now, but I'm pretty sure he's listed as a speaker. No, I know he's registered because he's listed as a speaker.
And it was 2020. Excellent.
Yeah, it was like WCH 20. It's the same because I wanted.
Okay. It couldn't get in with that email. Let me try a different email.
Which one did you use?
The one at Cabarrus Health.
Okay. Yeah. It was like the beginning of September when I did this. Let's see. It was like a long time ago.
I really appreciate you being.
Oh, no. I really appreciate you. And my least favorite thing is not to have things wrapped up. It drives me. So I love that you're on so early. I'm like, ooh.
Let's see. It didn't do Suda Russell. So let's try again. Russell.
And you're using the WCH in the right way, because I think like how I.
Maybe not.
Well, you got in, so it's the same way. I made it the same, like big W, small CH, 2020 exclamation mark.
That's see. All right. So I tried the Cabarrus Health and it wouldn't let me in. Oh, and created the account. So I would just need to be signing in. I wouldn't need to create an account.
I think because I'm pretty sure he's listed as a speaker. And what other email would I have used?
It would either be russell.suda@Cabarrus Health or Suda.
Yeah, I can't imagine it wouldn't have been that one at Cabarrus Health. I don't think I would have thought to use.
Sure. And the Cabarrus on the password is capitalized, right?
The Cabarrus on probably meaning his.
The password that you created. Yeah, I have.
Oh, I don't remember.
No problem.
What did you? Okay, I don't even remember because I've done so many ones. Is that what I did? Is Cabarrus? I don't even remember.
It was Cabarrus Sun 2020 exclamation mark.
Okay. How long did I send that to you? That was in the beginning of September. Let's see. Because I registered other people. That's why I'm like getting all confused. Because I like registered a bunch of people.
I get it. All right.
It should be the same exact because I did the same exact thing for both of you. Right. That's why
I remember.
Yeah. So if it was capital, it should have been. Maybe I didn't register him.
Okay.
So we can create an account now.
Okay, let's do it.
I think anybody can register anytime. I mean, we don't really say that, but I think anybody can do it.
You want me to create the account?
Yeah, go ahead.
I wonder if you'll have to check in with an email. That's the only thing. Like if it sends you an.
Oh,
right?
Yeah. Because I think it does a confirm thing.
Does it? Then we won't be able to.
I don't remember.
Let's see.
I'm really surprised he's not in there, but I guess I shouldn't be surprised. I guess I was so focused on you. I swear I thought I created an account for him. That's why it's bothering me.
I haven't. I'm trying to find your email. For some reason, I feel like you said you were going to do for both.
That's what, and I'm not finding the email. That's what's annoying me.
Yeah, look at this. Russell Suda Cabarrus Health has already been taken, so I can't create a new account.
Yeah, so that's why I was like, maybe he never confirmed.
Maybe.
So that it's in his, you know what I mean? Maybe if he never confirmed anything, so it's like in cyberspace, like he had, you see what I'm saying?
Yes. It's funny
because I was like
things now, right?
Yeah. So I bet that's the issue.
Okay. Yeah, he does not check his work.
His email. Well, do you want to try to log in under yourself twice and see if it lets you present and put yourself? Actually, the more I think, I don't know what it projects. So let's see if it logs you in twice. Let's just do that. We'll go back to that.
Okay.
But I bet that's the issue, is that he got the thing and he didn't confirm it, but he's in there. Yeah.
Yeah. I usually manage, when it comes to technology, I usually kind of have to manage that for him. It let me in.
It'll let you in. Mm-hmm. So I've been able to log in twice. It's just I want to know what projects on the screen. So that's why I want to see what you do.
Your upcoming events. Let's go to the virtual conference.
Because I don't know if it'll let you project twice.
And I don't know that as he needs to project, right? So as long as I'm doing the projecting and he's just talking, he's unmuting himself when he needs to.
Right. The other thing is just hand the computer physically to him.
That's what I was thinking. That's what we're
Yeah,
doing. I'm just going to wear a mask and
wear a mask and then hand it to him. I mean, that would be, because then at least he's on camera. They see him. That would be my suggestion.
Sure. Rather than logging in twice.
Well, see if it works logging in twice. No, you could still try. I'm kind of curious if it'll let you in twice to present. I don't know. You might get some feedback.
Yeah.
Just to let you know.
Oh, yes, it did. So do you see?
But I don't see you projected twice.
That's because I haven't shared audio and video. Let's see. Hello?
Oh, that's true. You didn't share your video. Duh. I'm a little slow. Oh, yeah. You're dark, but yeah, it lets you in twice.
Okay.
So it just shows you Gina twice, but that's fine.
Okay. Fantastic.
Well, that's good. That'll work.
Okay. We will get set up in different rooms then. I'm going to make this.
I guess you can have like bunches of you, because I guess you could keep logging.
All right. Let's see if you can see me again. Okay. This is fantastic.
Yeah, that's good. Oh, so I wonder if the audio, did you turn off the audio in the other room too? Okay.
Just for now, because my little girl's in there, so.
Yeah, no. I think that makes sense. Yeah, that'll work.
Okay. Problem solved.
Okay, let's just see. Can you share your slides again just to make me happy?
Of course. So this is when I would share my slides.
Okay.
I'm going to move through them, and I'm also, you'll monitor the chat, won't you?
Yeah, I will.
Okay, so that way I don't have to be.
Can you make them? So I can't make them bigger. That's interesting. Why I can't make them? You're in the reading? Yeah, you might want to make them bigger. Go ahead and make it a little bit bigger. A little bit more. A little more if you can.
Okay.
The reason is they'll be able to maximize them. That's perfect, because I can take a picture of what you look like, but the slide is big above and then the pictures are below, but it was small above, and I wasn't able to make it bigger, but you just did. So that's good. So that all the people watching now, they can make it smaller if they want. They can still click on it, but I was trying to make it bigger. That's good though. I
remember somewhere in one of the instructions it said, double click on the video area to expand the speaker or screen share view while on session.
Meaning as the viewer, yes, but still it wouldn't let me make it any bigger than it was.
Yeah.
For whatever reason, it may be your Mac. I don't know why, but all the other people, I was able to make it bigger, but I couldn't do that by clicking on it. It only says click twice to minimize the video.
Okay.
It doesn't say click to maximize, which is
big enough
interesting.
where you can see it?
Yeah. I think it's fine. Mm-hmm.
Okay. I can make it. Is that better?
Yeah, I don't want you to lose. Go ahead and go forward. Click a couple. I don't want you to lose your slides by making them too big.
Can you see all the way to the end?
Go on. Yeah, I can. Yeah, I think that'll be fine. Mm-hmm.
That's going to be okay. All right. Because I'll need a transition halfway through. And so the way I'll do that is I'll stop sharing and then I'll go to Chrome and you'll get to see this instead. And you can see that, right?
Yes, I can.
Okay. And is that big enough?
And the nice thing is it lets me maximize and minimize. So yeah, it's definitely big enough. Your slides, because I'm the same way. The graphs and stuff, it is what it is. It's sometimes harder to see.
Okay. Great. Thank you for working this out with me. Dr. Suda should be here about 1:30.
No, that's great. I'm glad. Like I said, I had a mini panic attack. I'm not really, but But that night when I emailed the instructions, because I'm like, oh my God, there's a Mac. I'm like, oh,
I know.
It's like, it was, and I was like, this is a lot for people who are like speaking and volunteering, and because it's like, and then we don't really, I mean, we have not really tech support. I mean, I'm used to doing my own IT, but I'm like, this is a little much for, and I was like, oh. So that's why I decided I needed to like send some specific. And then when you said you were doing a Mac, and then I'm like, all right, last night I was like, okay, I got it. It wasn't as bad as I thought, but there's still a lot of steps. I mean, and if, I mean, there, it's not like click and you're like here.
It's not as intuitive as Zoom. I had to do my slide presentation. I had to pick a very specific way of presenting it, and and I did go ahead and did like all the privacy settings and making sure things weren't locked. But I've gone on before.
So Zoom makes you do that too?
No,
okay. Yes, I didn't think so. I didn't think so either. So this platform is new for me, but thank you. So you're like the first Mac, and then I have another person who's doing a Mac. So hopefully I mean, I kind of see, I mean, it does seem like it works. So that
is good. That is great.
Yeah. Because there have been some hiccups. I mean, not surprising. I heard in one of the sessions, they spent the first 20 minutes trying to get the IT together. And I was like, I mean, you know, it's understandable but I was like,
I know.
So,
yeah, it's tough. And it makes both the speaker, I think, anxious, and the participants wear out a lot quicker.
Yeah. So I appreciate it. Okay. Well, I think we're good. I'm thrilled.
I'm going to I'm just going to take my camera and my mic off, because in a little bit
Yeah. I'm going to take mine off too.
And then you want to join back on once Dr. Suda comes in around 1:30?
Yeah.
Okay.
Yeah, that sounds
good.
Thanks. All right. Bye.
You're unmuted now. See
Yeah.
how it doesn't have a line on it?
Yeah, but if I want to mute back, then I just go like,
That's interesting.
there it
Yes.
goes. Kind of right in the
seen-
center.
I'm going to turn this out.
Yeah. Oh, you know what's a little time?
Hello, Dr. Suda. Oh, you might not hear me. Disheveled myself. Oh, you can hear me, Shauna. Okay, Dr. Guthrie. Great. I think he's on mute. Our session doesn't start until 1:45, just to let you know.
Dr. Sue, can you hear me okay?
No. 1 second. I'm on. Can you hear me?
I can hear you.
I cannot hear you.
Okay.
We can
I
hear you,
see
Dr.
a
Suda.
little microphone with a light, a halo going around it, but I don't hear you. Excuse me.
Sure. So here's the volume up and down.
Oh, yeah. Okay. Okay, good. Go ahead and talk first.
Sure. Can you hear me now?
Oh, my gosh, yes.
Okay,
Can you hear me?
I can. I've got you turned down pretty low so
Okay.
that there's no feedback.
I think that's good for me. I mean, if I can hear you just right,
Okay, perfect. And I'll ask the participants if they're hearing feedback.
We can all hear you.
You mute yourself while I'm talking and I mute myself. Hi, Dr. Matson.
Hi, Dr. Suda.
Hi, Dr. Madsen. It's nice to have met you.
Good to meet you. You look familiar to me because I've seen you in pictures before.
Well, it can't be Hollywood stuff. I know that.
No. So we're starting to get people in the session. So welcome. Thank you both for doing this. And I'm glad that Gina and I were able to troubleshoot and figure out all the stuff. So I think we're set. And it was, I'm not sure we can apply the knowledge to other places, but it was still interesting to figure it out.
IT is not really to be figured out. It's always got one leap ahead.
Right. Well, this platform is just different than others. So that's why I'm learning and getting to know stuff. So we'll be starting at 1:45 in 5 minutes. And it looks like we have about 6 people. And Amy Hendricks is one person I recognize. She is, I think, with the ARC of North Carolina, and she leads the efforts in the state around fetal alcohol spectrum disorder prevention and awareness. I don't know if you're familiar with there's a lot there. They have a great website. I don't know if Amy, if you want to type it in the chat box, great resources about fetal alcohol spectrum disorder prevention and alcohol use. And Dr. Guthrie, who, so I can tell you some of the people on there, is a family physician at Granville Vance, their district, their health department. So she's their medical director. Dr. Suda is the medical director at Cabarrus Health Alliance, Dr. Guthrie. So
nice
there
to
you
meet
are.
you.
There you go. I won't be able to introduce you to every single person here, but I do recognize those two.
Dr. Matson, when we speak, are you hearing a lot of echoing back and forth?
Not really. Mm-mm.
Those who probably are used to this by now, if you click on the slide, that will maximize your slides. You certainly can click on the speaker video as well, but if you click on the slides, that will maximize the slides. And then click twice. If you click twice, you can maximize. If you click twice on there, you will minimize the slides as well. We'll get started in a few minutes. Share while we're waiting is I heard about the substance use network at Cabarrus on a national level. So I'm in North Carolina. I work with all the health departments, but I said, oh my goodness, I need to find out more, and we need to have them talk about this in North Carolina more. So
Thank you for that. That's nice to hear.
That's wonderful. Thank you for inviting us.
Thank you. And you're going to be presenting at APHA a couple of weeks, I think.
We were initially accepted to present, and then they had to redo everything because of the going virtual. So then we got shifted off once they redid the schedule. So I was like, oh.
Well, what I can do is when I get this recording, I'll send it to some people I know in the maternal and child health, and they'll at least they can see the recording. So just to let folks know, this is the Women's and Children's Health section. It is about substance use, the Substance Use Network effort, and a program is going on at Cabarrus Health Alliance. We'll be starting in a minute or so. So just to let you know that the session starts at 1:45. Okay. Well, we'll go ahead and get started. We can say we'll start promptly. So welcome everyone again to this session on the Substance Use Network at Cabarrus Health Alliance. I'm Jerry Mattson. I'm a pediatrician who works for the State Health Department across North Carolina, but I'm based in Raleigh, although lately I'm in Chatham County right now. And we have the pleasure of learning more about the Substance Use Network from two key people involved with this effort. And you see them on the screen. And we have Dr. Russell Suda. He is the medical director at Cabarrus Health Alliance, the SUN Project. After 30 years as an obstetrician, he retired last year from delivering babies and now focuses his work on high-risk pregnancies, including women with a substance use disorder. And then we have Gina, is it Hofert? I should have said Hofert. Okay. Is the SUN project manager at Cabarrus Partnership for Children. Cabarrus County Partnership for Children. She helps secure grant funding and coordinates partner collaboration and system level work to support the clinical arm of the SUN project. And so we have Ms. Hofert and Dr. Suda here for us, and I'll let you guys take it away. Thank you again so much for presenting and sharing your amazing work and project.
Thank you.
Thank you, Dr. Mattson. Welcome, everyone. This is the Substance Use Network. We're going to be sharing what we've been doing in Cabarrus County, and that's a collaborative cross-sector approach to the treatment of pregnant mothers with a substance use disorder and their families and infants. With me is Dr. Russell Suda, and we really appreciate it. I know it's been a long day, I'm sure, virtually, but feel free to engage us via the chat box, and Dr. Mattson will facilitate that, but we'd love your questions and comments. It'll make it a little more fun on our end, and I'm sure on yours as well. Dr. Suda, if you can start us off by giving them a background on the project.
Thank you, Gina, and thank you, Dr. Mattson and everyone from the North Carolina Public Health Association for giving us the opportunity to talk about something that we're excited about and hopefully will continue to grow over the next few years into something that's very effective for our region down here. And our region has the southern Piedmont region, which includes Cabarrus County, Rowan County, and Stanley County. The SUN project really got its start in May of 2015, but I'd like to take you back a little bit further background as to how this project came into being. If you go back as far as 1998, the state of North Carolina had the home model tested and putting together best practices for mainly Carolina and emergency room and in the primary care offices. And it took them 4 years to realize that best practices had to be worked out, brought back to a central area where people could talk about how things should be done to make it work better in the community. They started that process about 2002, and by 2006, they were had created a lot of effective primary care medical homes in rural North Carolina. And the statement for me was that from 2006 to 2009, they saved North Carolina $150 million by coordinating care, bringing the primary care medical home model to the people of rural North Carolina. Somebody got the idea, and I tell you, but trying to apply this to obstetrics. And in February 2011, I was asked to represent the Vermont region, again, Cabarrus, Rowan, and Stanley counties, as one of regional representatives from the state of North Carolina, which would look at clinical pathways in obstetrics with the intention of making them more time efficient, quality efficient, and cost effective. I joined that team in February 2011, and we began conference calling every month with regional directors around the state. It was led by some very scholarly people, Dr. Kate Menard, who was, is the head of maternal fetal medicine at UNC Chapel Hill. There was also leaders from the Duke Medical Center, East Carolina University, Wake Forest. So we had academic physicians leading it, and the collaboration, though, was at a regional level. And every 3 months we got together in Raleigh to speak over the course of 2 to 3 hours to the project's goals, objectives, and where we attained. The clinical pathways came out in areas of obstetrics, which, as you might imagine, affected high-cost areas with problems. And of course, the big ones were preterm delivery. So we looked at cervical insufficiency. We looked at preterm labor. We also looked at the C-section rate and how to reduce the C-section rate. But one of the pathways that came up was the substance use disorder, because we were in the midst of the opioid epidemic. And we really had very little guidance or leadership as obstetricians in managing substance use disorder patients. And I think it's worthy of note to bring up the fact that without wanting to stigmatize patients, many obstetricians felt very, very uncomfortable with managing a substance use disorder patient in pregnancy, because these ladies were taking in drugs that were known to cause serious preterm delivery problems, growth restriction problems, and on and on. And of course, placental problems with abruption of the placenta, post-abruption hemorrhage. These things were all very, very serious diagnoses. And physicians, obstetricians really had a problem with these patients because they didn't have the skills to bring these substance use disorder problems under control. To a great extent, that was because the support stakeholders in the care of substance use disorder really didn't want to enter into the domain of obstetrics as well for the same reason. They were afraid of bad outcomes, medical legal problems, and whatnot. And so what had transpired, 25 years of the opioid epidemic and its evolution, was no progress was being made. More women were showing up with substance use disorder, or at least misusing opioids in pregnancy, and yet were not able to get in and get care because obstetricians made it difficult for them because they did not have the support. One second.
A quick break. I'm going to log you off.
Okay.
We're having some feedback, so we're going to log off here.
One second. I'll be right back with.
We're just going to.
So they didn't leave. I'm trying to address the sound issues. And so we were just trying to address that so that the feedback would be a little
back
better.
With me here?
We're all back. Thank you, Dr. Suda.
I'll assume that means yes. But,
yes, can you hear? Yes, we are back.
it was around 2000, it was actually 2014, thank you, Dr. Madsen, that we really started putting together a substance use disorder clinical pathway for pregnant women. This was no small enterprise. I mean, there was a dearth of literature out there on this problem. The people who were looking for guidance had very little in the way of guidance. But about that time, the literature around and give some guidance. So it took us longer than any other clinical pathway that we put together in the Pregnancy Medical Home Initiative. It took over a year to put this clinical pathway together. But when it came out, it was approximately 20 pages. And of course, it incorporated all the major stakeholders into the care of the obstetrical patient in a collaborative fashion. It included, for instance, behavioral health, all the way up to psychiatry, pain management, not just for the delivery, but dealing with pain that was the original cause for these patients, many of these patients, to begin substance use, addiction medicine. We also dealt with neonatology, and of course, primary care, obstetrics and pediatrics. We began to look at these other entities and how, in an ideal fashion, we could all come together and serve this population. So in May of 2015, I went to Atrium Northeast and presented to the OB committee and to the maternal fetal medicine committee at that hospital about a desire to start looking at these other stakeholders in the care of substance use disorder pregnant patients and seeing if we could put together a team, a network, in such a fashion that patients could be, with great facility, move through the expertise of all the appropriate stakeholders, just as if a patient had a cardiac problem, getting cardiology to come in and look at it, getting echocardiography people to do their services in conjunction with cardiology. Those were never really a big problem, but in substance use disorder, that was off limits. So by June of 2015, I went to Cardinal Innovations Healthcare, because they were the head of the MCO for the mental health care dollars for our region. And I presented what I wanted, what we wanted to do. I say I really mean we. When I say we, I mean the Pregnancy Medical Home Initiative. I was the obstetrical representative of that district, but there was a nurse coordinator working with me. And of course, we were reporting back to the Pregnancy Medical Home Initiative as well. And Cardinal came across very, very supportive. I was very energized by their desire to see stakeholders come together to manage this very fragile and very underserved population of patients. And I'm going to compress the next 2 or 3 years into a short, explanation of what happened. But I spent a lot of time, along with my nurse coordinator, making appointments with the psychiatric institutes in the area, with Cardinal Innovations as the MCO, with pain management, with addiction medicine. Our McLeod branch in Cabarrus County is very active in methadone treatment and now buprenorphine treatment as well. And I also talked to hospital-based services, including ERs, neonatology, anesthesiology, because they were also involved in pain. And basically, as I went around, I got a lot of interesting looks, and a lot of interesting responses. Some were quite frustrated. In the area of pain management, they were very frustrated because they felt like too many obstetrical patients were being left at their doorstep, and they didn't feel like they were being treated fairly. And as I went around, I got that sense from the other subspecialties too. And it kind of explains why originally, before all this started, you could call for a consult for your pregnant substance use disorder patient. Not infrequently, you would get an answer like, oh, listen, we'll take care of her, but we don't take care of pregnant patients. When she delivers, we'll be happy to see her. And of course, that wasn't answering the call that we were talking about. So we started moving on from that point, and I got so busy talking to so many people and institutions that my nurse coordinator had to bail out because she had other responsibilities that in the Sun Project, the early part of the Sun Project was taking up too much of our time. So I took it on for about a year, and we just naturally slipped into the criminal justice system, including parole, the district attorney's office, the judges, both the family judges and the Supreme Court judges in Cabarrus County, law enforcement, and all these other entities, emergent EMS services, ambulance services, that naturally contacted this population very frequently. And by late 2018, we were beginning to slow down and not make any progress because I really couldn't go any further. As a physician, I was at my limit in putting collaborative systems together with stakeholders I knew only kind of peripherally. I really needed a program manager, and that's when the Cabarrus Partnership for Children stepped to the plate in the person of Ann Benfield, and she went and got we got a grant, and we hired Gina here. Gina's one who is with me today, and she's become the organizer. She's the program manager. She really runs the governance branch of the Sun Project, whereas I'm primarily in the clinical branch, although I certainly go out and speak to stakeholders that are related to these the management of these patients. But Gina does the organization there. With Gina's organizing powers, we started working on actually signing memorandums of understanding with all the stakeholders, and we now have 10 memorandums of understanding in different institutions, including DHS in Cabarrus County and in Rowan County, with Daymark Psychiatry, Atrium Health Services, ourselves, the Cabarrus Health Alliance, and others. And so about the end of 2018 is when we really started recruiting in patients to the Cabarrus Health Alliance Obstetrical Clinic. And these patients were called SUN patients, Substance Use Network patients. They were substance use disorder patients who were pregnant. And since that date, we've gone to close to 25 patients now, 13 of which have birthed babies, 10 of which have been full-term healthy babies, two of which were mildly preterm, and one was significantly preterm at 31 weeks. But we're feeling like these patients are getting the kind of care that they need in order to produce a healthy full-term baby. And at the same time, during that period of time, starting in November of 2018, I became a waivered physician for prescribing buprenorphine, and I was prescribing buprenorphine for patients who arrived at our clinic. Initially, I was accustomed to managing methadone patients that were sent over from McLeod, and some buprenorphine patients that were sent over. But I began real quickly to realize that I was up to my neck trying to manage heroin addicts who had taken heroin the morning of their appointment to see me in the OB clinic. So I fell back on, in great relief, help from Dr. Steve Wyatt, who's the head of psychiatry for Atrium, his addiction psychiatrist, Dr. Sarah Longest, who's out at the Jones Rehab Center in Eastern North Carolina, and through conversations with them about patients and their presentations, and also working with ECHO, looking at some of their virtual presentations, webinars, I began to learn how to manage patients with buprenorphine in the acute phases of transition from hard narcotic addiction on the street to prenatal care in an obstetrical clinic. And that was very, very helpful because these patients do very well on buprenorphine. It doesn't mean they don't cheat at times, because we certainly do our share of urinary drug screens, and it's all informed. None of it's covert. We want to make sure the patients know that we're doing this for everybody the same way, and we're being honest about it. But we have been very happy that we keep moving forward, and our referral base is really broadened. We're getting them in from Rowan County very regularly now. We're getting them from ERs. We're getting them in from primary care. We're getting patients referred even from the court system. So our syringe program, Cabarrus Health Alliance, has yielded 3 or 4 patients. So we're getting a broad base of referral, and we're learning all the time. And what I'm happy to report is, my gosh, with collaborative care and putting all these experts together and having a monthly care coordination committee meeting, which we actually had this morning from 10 till 12, we get all the experts to answer questions about patients that we discuss under a very strict confidentiality platform that took us a whole year to put together with the School of Government at UNC Chapel Hill, and Dr. Mark Botts, who is the attorney who worked with us, and we with that kind of confidentiality latitude, we can talk about patients, openly in a very, very secure platform, Microsoft Teams, and go over patient management with everybody participating. This is not unlike the tumor board format, which has been adopted for 50 years in cancer management, because it too depends on a collaborative intersection of specialists who know what is best from their perspective for a patient with a given cancer under the present circumstances of that patient's clinical presentation. And we really kind of borrowed on that tumor board concept, and it's really worked well. So that's the background. The other thing I would say is that, my gosh, as soon as you leverage pregnancy positively for these substance use disorder patients, you are taking the biggest stigmatizing label and converting it to the biggest positive motivational agent that anyone can have. These women, when they're told that they're showing up for prenatal care, is courageous, and we're very proud of them and very impressed by them, and that we're going to team up with them, and that we'll be there for them throughout the pregnancy, and I provide buprenorphine for a year after the pregnancy, that we'll be with them even part of the year when they're adjusting to having a newborn. It's absolutely amazing how lives can change. This is low-hanging fruit. It's 20 years off. You can see changes in people's lives in weeks. And I feel very humbled by the fact that I'm given the opportunity to witness this through the project. And that kind of brings us up to snuff, through kind of a history to date. So I'm going to look to Gina now to see if she has something that she would like to add. Remember, Gina really runs the governance arm of the Sun Project, and the governance arm absolutely has to function. You cannot depend on recruiting specialists or stakeholder institutions into their care, no matter how relevant to their care they may be, by simply sending a patient over as a referral or for consultation. It doesn't work. You have to go out and meet them. You have to talk to them, collaboratively, and tell them about the hope that exists and how important they are, and then you can build on that. So anyway, having said that, I'm going to turn it over to the project builder, and that's Gina.
Thank you, Dr. Suda. I do want to ask you, one of the things that you talk a lot about is using pregnancy as a way to uproot the opiate epidemic. Can you talk a little bit about why that is?
Yeah, if you look at the medical literature, American College of OBGYN says 4% of pregnant women in the most recent poll data collection were users of narcotic scripts, at least one during the pregnancy. Doesn't mean they all have substance use disorder, but they're using substances. As you move through different populations, it's very clear that in the Medicaid population, in the underserved population, in the economically deprived population, the numbers are much higher. And the numbers that you get are not accurate because they're underscored, they're spoken to, because patients naturally don't want to admit to this. So we've got a huge number of patients that are giving birth to babies without any other care than maybe some prenatal care visits, but maybe getting methadone from an outpatient treatment program, but many not getting any of that. And they deliver sick children. They're fighting to keep custody of those children. And what happens is the families are very fractured. They're not coming together as a family, a functional family. And the children have very high ACE scores. That's adverse childhood experience scores. And it leads to this indexed generational problem of substance use. Those children, when they get through their childhood, hit age 12 to 18 is when 90% of people start using drugs, who end up using drugs. They turn to the coping mechanism that their parents turn to, and that is the use of drugs. What we're trying to do in the SUN project is not stop at the delivery. We have got a lot of social services, behavioral health services, coordinated so that these patients are maintained on a pathway towards a functional family. And when we get to the patient in the pregnancy, we're talking about who is it that should be in your family? Where can you live, and with whom that you can live a positive life and give your newborn child the best environment for both you and your baby to grow. And so the point that Gina brings up, and I'm trying to put together an article right now and a presentation on this, is that the numbers support the fact that if you don't manage pregnant women with substance use disorder, you just allow those mothers to keep giving birth to babies that are new recruits into the next generation of substance users. And that's why the opioid epidemic, there's a lot of reasons, I know that, and I could name them all, and most of us can, as to why people become substance users. But certainly one of the biggest is because we're not taking care of the unborn baby with the mother, leveraging the pregnancy positively so she goes into recovery, gets a healthy full-term baby, and can put together a functional family so we don't keep pushing babies, children, not just one child, multiple children in many cases, into substance use. And I could sit here and go through case by case of the number of patients I talk to, and I ask them about their history, and it's just amazing how their parents were substance users and abusive parents. That's closely associated with substance use as a parent.
Thank you, Dr. Suda. So you're going to see here on your screen, if you're a visual person, what our goal is with the Substance Use Network, and it is developing a compassionate, and that's huge. Dr. Suda talks about his journey from having that stigma towards these patients to recognizing it as a chronic disease. So having that compassionate cross-sector collaborative system of care that is using and founded on best practices, and that is supporting the health, safety, well-being, and recovery of not only the pregnant patients that have that substance use disorder, but their infants and their families, and recognizing that unit. Dr. Suda referenced a lot of different clinical pathways, and this looks overwhelming and complicated, but we can't do anything in public health without some charts. And so this is kind of our way of how you can see how some patients come into the clinic, and that it's very pragmatic in where they connect them to make sure that they're getting all the different resources that they need to go into recovery. And at the SUN Clinic, which is the clinical arm of the project that Dr. Suda heads, That's where they receive that obstetrical care. They can receive the mat therapy via buprenorphine. They get case management by Sonia Bahana Thacker and an amazing team, OBC ends there. And they get behavioral health counseling. We have access to peer support specialists. There's also syringe exchange services downstairs, where there's a really nice connection being in the public health department. And then being able to get psychiatric consults through Project Echo and our partners has been really huge. I want to show you, and bear with me while I work the technology, some coverage that we got for one of our patients. Sometimes it's easier if you can kind of hear it. And so I want to do that. Dr. Mattson, if you'll let me know if you're not seeing, if you're not hearing it.
The bill that passes and everything we would have wanted in it was part of the Medicaid extension bill.
I'm not hearing it right now.
This step forward, and we build more in the future. The other bill that passed was called.
And for those of you who are watching, if you want to click on it, double click on it to maximize it.
People will do anything at all costs to stop the hurting.
The opioid epidemic touches every person, and that includes expecting mothers.
One group in Cabarrus County is working to provide the critical prenatal care they need while treating their addiction too. Channel 9's Susanna Black has more.
When you worked with that girl 3 years ago.
Oh, my goodness.
But the woman in the photos is Desiree Arts, unrecognizable to herself back in 2016 at the height of an opiate addiction.
You're so wrapped up in chasing the high, and not only are you fighting, your family's fighting.
Now Arts' family is about to grow by one. At 5 months pregnant, she's ready to get help. But as a pregnant mom with a substance abuse disorder, she says that's easier said than done. So finding Dr. Russell Suda,
I get excited.
was a godsend.
We're explaining to them, number one, we're really proud that you've come into this care.
As the medical director for the Cabarrus Health Alliance, his long career as an obstetrician gave him the vision to create the Substance Use Network, or SUN project. It's a collaborative approach to care between area providers for these patients who are too often turned away. Care, he says, that can increase the birth age and weight for babies born to mothers with addictions and even reduce the number of babies removed from homes through social services.
We're getting psychiatric support. We're getting social service support. It's a whole new world, and it's really taken me by surprise.
This kind of work takes years.
Gina Hofert manages the project and says they're already seeing around 20 moms gaining strength over addiction.
For those of us that are moms, we know what that feeling is like, to be able to now make a change, not just for yourself, but for the child that you're bringing into this world.
Art says she now knows that feeling.
This is probably one of the first times in, I'd say, the last 6 years that I've looked forward to the future.
Susanna Black, Channel 9 Eyewitness News.
We posted
Dr. Suda, is there anything else that you wanted to add as you see that story with Desiree?
Yeah, excuse me. Desiree lives with her mother and has good support, but she wants to get her own place, and we're going to be working with her to get her own housing and to be with the father of the baby. And create that functional family that we're talking about, because two of the biggest steps that you can do for these patients is get them a full-term healthy baby so they don't have to follow a baby around in a regional NICU setting, for 6-8 weeks, and then get a sick baby when the baby gets discharged, because they're never going to be as strong as if they were born healthy and born, full-term. And then the second thing is to make sure that after the delivery is over, that the collaborative care that's been coordinated for this patient dissolves and goes away. When I was talking to my obstetrician colleagues at the Northeast Atrium, their biggest problem with methadone patients is they would work with those patients through the pregnancy and get a decent baby, but then they wouldn't see the patient for 3 or 4 more years. They come in,
and they had to start from scratch. They weren't any better, or they were worse many times. So trying to extend the coordination and comprehensive nature of the care in a collaborative fashion after the delivery of the baby is critical. You cannot lose touch. That's why primary care, our Cabarrus Family Medicine, we've recently had a wonderful meeting with them, and they're stepping up, taking these patients, because our first patients now are, we got several that are a year out from their delivery, and they're looking for primary care. And just like obstetricians, primary care doctors really worry about having too many substance use disorder patients on mat therapy, because they can be complex and take up a significant amount of time, and be open to coming in frequently. However, that's being approached as well. This is a large group of Cabarrus Family Medicine doctors, and they're looking to share these patients. So, and remember, the patients we're turning over to them, we will not turn over unstable patients who are, dabbling in polypharmacy for much of the pregnancy and really are not in full recovery, or at least early recovery. We are turning over to the primary care doctors, the family medicine doctors, patients who have been good. When I'd say good, I mean following the instructions, and for the most part, having urine drug screens that show no or few illicit drugs during the pregnancy. For patients who are unstable and are really in need of more intense care, and we certainly have our share of those, we're trying to move them on to behavioral health services with addiction specialization, so that these patients can get more intense therapy, even if needed, inpatient therapy, so that they can get on the road to recovery and intersect their child's life after sometimes DHS steps in, sometimes family members step in to watch those children while mom's going through a more intense recovery process.
Thanks, Dr. Suda. So for those of you who are in public health, you know that it takes resources and partnerships in order to make something like this come to fruition. So I think that's what Dr. Suda referred to when he had done all he could. He had built relationships, he had gotten the community buy-in, but then how do you move it from a vision to actually logistically looking at having collaboration in place so that you can discuss cases, especially around the use of substances, where everybody shuts down. Nobody wants to disclose anything. Everyone's terrified of, HIPAA and 42 CFR Part 2 and additional state regulations, rightfully so. And so what we were finding is that care was fragmented due to those protections, and we needed to find a way to legally navigate them so that we could provide collaborative and coordinated care. So we did this by applying for a grant through the Robert Wood Johnson Foundation. They funded the Cabarrus Partnership for Children through the Cross-Sector Innovation Initiatives Grant. It's actually administered by the Center for Sharing Public Health Services and the Public Health National Center for Innovation. And that's been really, really great, because you just have a pool of experts and toolkits and resources and other grantees who are doing similar initiatives and coming across a lot of the same obstacles. And so getting this funding has also expanded our network of other people who are in the nation who are trying to accomplish much of this kind of collaborative care as well. A lot of what we aim to do is systems alignment in public health, healthcare services, and that includes behavioral health, and then social services. So the goal really is to improve population health, well-being, and equity for all. And we want to do this driven by the voice of community members. And oftentimes people say that they do that, programs say that they do that, but it's kind of done superficially. So we have to admit that that's a challenge for us. We're looking at a population that's difficult to get to come in just to their appointments, let alone for, filling out a survey or a focus group. But we have to be very intentional about making sure we include them in that process as well. When Dr. Suda refers to the governance arm and the clinical arm, you see in other communities this very often. So you'll have a kind of not within healthcare, but you'll have community agencies that get together and they form task groups or mental health task force or coalitions. But often who you'll see missing at those groups are doctors themselves, physicians themselves. So you have, healthcare and the clinical arm operating, and then you've got, folks out in the community who are trying to coordinate things, but they never actually talk and intersect. And I think this is what's unique about the Sun Project, is that we were able to bridge these two arms through something called the monthly care coordination team meeting. So you've got the Sun Clinic that operates where they see the patients. Then the team meets weekly to kind of go over the logistical pieces of the clinic. And then we get together once a month and we bring in all of the partners across all the sectors: criminal justice, social services, housing, nonprofits, pain management, primary care. All of those come together and, like Dr. Suda referred to as a tumor board, sit together and go case by case and say, this is where we are with this patient. This is what she's needing. These are her goals. How can we coordinate this? How can you help? And this really helps not only become more efficient, but effective as well. So we're not duplicating services. We're not overwhelming the patient by her getting 25 different directives from 25 different agencies, because we're all sitting together at the same time and leveraging who has the most positive relationship with them. Sometimes a patient will trust, one agency more than another. And so that's how we can kind of get the information and services to them. And then it doesn't stop there. Once we're managing those cases, things pop up pretty regularly, systemic things, policy level things that we just keep bumping into and are obstacles and barriers for us. And that's where you have the steering committee and the oversight committee, where we can get together. Steering committee people are mid-management level folks, those who know what's going on, the program managers, the clinic managers who can say, yeah, this will really work or this won't work. But when we come to them and say, hey, we're really having trouble getting patients admitted, and they say, oh yeah, we'd really like to help you, but there's a policy in place that says I can't, and I don't really want to lose my job over this, right? So that's when we need folks at the oversight committee, and those are our CEOs, and our execs who are able to change policies, who are able to help us logistically work out the legal nuances, who are able to advocate for us, with the legislators. So it really has this framework, which we can't take credit for. This is actually from the Substance Abuse and Mental Health Services Administration. They actually have a guidebook and the sources there at the bottom. Mm-hmm. This structure has allowed frustrations that were previously being felt at the clinical arm from providers to be navigated, so it didn't just stop there. You can see here in Cabarrus, we have 10 agencies that meet with us, and I won't name them, but you can see kind of the depth and variety of agencies that they get together. And for those of you who are data nerds, I'm an evaluator at heart, so I always love looking at the data. But if you're wondering, how is this working in Cabarrus? Are you seeing a change? So, anecdotally, we can hear from Dr. Suda and our social workers and our other providers that patients are doing significantly better. They appreciate the level of care, the resources, and what the Sun Project is able to achieve. But what I was interested in measuring is how that collaboration is actually translating into better use of best practices when it comes to managing pregnant women with OUD. So we took a baseline score, and providers and representatives across 5 different sectors completed to what degree practice. There's 20 domains or 20 best practices being measured. So on that left-hand side, what you'll see is the level to which that practice is in place. Lower down means it's not in place. Up higher means it is in place completely. And blue is the baseline. And then you'll see that yellow was our 1-year follow-up. And it was really, really nice to see that after 1 year across all 20 domains, across all 20 best practices, collaboratively as a community, as a county, Cabarrus County as a whole, had increased those mean scores across all of those best practices, meaning that collaboration is working at instituting those best practices, not just within one sector, but towards that systems alignment. I just put this as your reference. I don't expect you to be able to see them, but if you're wondering what that 1 through 20 at the bottom is and what those 20 best practices are, again, those are derived from SAMHSA and they're listed here just for your reference. I'm actually going to give everybody about a 5-minute break. I have been on enough Zoom calls and trainings to know that there gets a point where you're just fatigued and you just need a little bathroom break, or do you need to refill your coffee? And so we are going to, with Dr. Mattson's permission, take about a 5-minute break. So we will come back here at 2:35. And during that time, if you want to go ahead and put in some questions in your chat box, we would love that. Dr. Mattson, are you okay with that?
Totally fine. Thank you. So please type in the chat box if you have any questions, and we'll be back in 5 minutes.
Thank you. Well, welcome back. It is 2:35, so we're going to pick back up where we were. I am going to ask Dr. Suda to talk about our work, and you were talking about policy resistance and what people may come across. Do you mind talking about that to our audience?
You know, the kind of project that we've got going here in Cabarrus County can really go anywhere, but be ready for resistance. You know, the stakeholders, and I'm not going to name any one stakeholder over another stakeholder, but the stakeholders who play a role in substance use disorder care in the community have to realize that it is not a barrier, and that policies that are intact right now and in effect right now, oftentimes were policies drafted in order to exclude these kind of patients because they were felt to be medical legal risks, high medical legal risks, and they wanted to stay out of that domain and really help see the patient after the delivery. So if you're going to start something like this and you're going out to recruit institutions, collaborative, expect resistance and expect a need to go high up in the institution, sell your efforts, and then get those people to get on board to change policy. Policies tend to be institutionally centered in many communities and most communities around these patients, and they need to be patient-centric. As soon as they become patient-centric, you'll see progress. But you cannot do it if you're trying to serve what you perceive as your medical legal risks more than the pathos that these patients bring to you when they're pregnant. And I can say this wholeheartedly, that the perception of medical legal risk is ridiculously emphasized and over-amplified. In 5 years of reviewing this literature and doing the SUN project, I have not seen anywhere that this is a high-risk medical legal area. And in addition, think of it. If you're bringing a collaborative together of experts, how can you fear a legal lawsuit, even with the worst outcomes, when you've got the best people serving in a subspecialty arena collaboratively on their care? It's not going to happen. So I want to make sure you understand, if you try to do this in your community, you're going to have to overcome a certain amount of resistance, and do not get discouraged. And you can give us a call down here. I mean, if we can help out and tell you what we experienced, we'll be happy to do that. Not that not that we have all the answers, because certainly we don't. But we would be more than happy to tell you what we experienced and how we dealt with it.
Okay. We do have a question from the chat box, Dr. Suda, from Amy Hendricks. She says that she loves the compassion being shown by the SUN project. She's curious if your staff screens for alcohol use.
Yes. We actually do screen for alcohol use. It's interesting, and we may need to go after that more zealously, because I suspect we're not aware of it to the extent that it's actually being used, because in all these drug use patients that are pregnant, you're going to get that played down. It's going to fly over the radar, and I think that may be what's going on with the alcohol use in our clinic. But we're looking at other drugs that are being used, and a certain number of women will tell us, "Yeah, I'm an alcohol drinker." Interestingly enough, it's been my experience with a few number of patients we have, 25 or so, that they tell us they get away from alcohol, and we're screening for alcohol on urine drug screen, and we don't see alcohol as being a big component of polypharmacy. We're seeing much more problems with amphetamines. And there was a recent article in the American Journal, in the Green Journal, which is the American College of OBGYN's journal, that amphetamine polypharmacy use with narcotics is the most common other drug used, maybe other than marijuana, with a 40% association with narcotic use since from 2012 to 2018 when the data was collected. So amphetamines are a big thing, and we have our share of problems with that. But alcohol certainly, as the biggest cause of teratogenesis in babies, in the first trimester especially, it really needs to be screened for as well.
Thanks, Dr. Suda. We'd like to kind of take you a little bit through some case studies and some delivery outcomes. I think it makes it come alive and show the kinds of problems that we were encountering and why we thought it was important to have a collaborative effort. I know when Dr. Suda was first introducing me to the project, the story that he shared was that he had a patient who showed up at an inpatient facility and she was pregnant and actively using, saying, I'm done, I'm ready for recovery. So she shows up to the front door and they say, oh, you're pregnant. Yeah, you're gonna need to get medical clearance first before we'll admit you. So you're gonna need to go to the Cabarrus Health Alliance or to a doctor, an OB, and get clearance before we can help you. So, they send her away. And you know how hard it had to be to get to that point where she was actually showing up at the front door. So she goes away and doesn't come back that night, doesn't come up to the Cabarrus Health Alliance, shows up the next day and says, I'm ready, but hasn't gotten the clearance. And so they call Dr. Suda, and he said, absolutely, admit her, go ahead and get her started in detox, and I will come by and I will, see her, do the chart, whatever we need to do. And they're like, oh yeah, no, our policy says that we can't admit her until we actually have a form. And so he says, okay, it's 5 p.m. of course on a Friday, but send her in first thing, Monday morning. And of course she doesn't show up on Monday. It was one of those things where it was frustrating that the patient was showing the initiative. Dr. Suda is saying, I will clear her, I will check her, but they were so, stuck in that I've got to, and they said it had to be in writing and it had to be faxed over. So, all of those kinds of barriers that just didn't make sense. We were saying, there's got to be a way that we can figure out a system that if someone shows up at your front door and Dr. Suda is willing to see them, that you can admit them and go ahead and start treatment. So those were the kinds of stories that we were hearing anecdotally that we wanted to address. Dr. Suda, do you want to go over some of the delivery outcomes that you've seen and some case studies that have been significant to you?
We've certainly had our share of patients that have frustrated us, but there's no question that the majority have done well. And I think it's just because our staff is so supportive. We're from the nurses to the medical providers to our front office staff. Everybody's there to encourage the patient and tell them how to come in and that we want to work with them to have a good baby. And so that really contributes right out of the gate to these patients identifying with us as friendly and supportive. But I got a call. I'm a miserable golfer, and I got a call on my cell phone from an ER doc. And, they had a patient who was pregnant and had been using heroin on a daily basis. And they wanted to know how to get her into the Sun Project. And so this was the first time this kind of a patient, I was getting called actually on my own cell phone about her. So I said, well, have her come by tomorrow. And I told them how to give her directions to get there. And sure enough, the next day I came in, she was there and very frightened, really wanted to have a good baby and had a partner. We couldn't see him because of COVID. He was outside. So we got a clinical opiate scale done on that withdrawal scale. And I was able to start her on buprenorphine that day, about 12 hours after her last dose of heroin. And I'll be darned, she showed up almost every visit on time, missed very few visits. She wanted to have that baby, and healthy baby, and she also wanted a family. She ended up marrying the father of the baby during the pregnancy. That was kind of a first. And all of a sudden, I'm getting calls from him because he's a husband and father to be. And lo and behold, she stayed with us. She wouldn't take Suboxone film because she made her sick, so we got her on Subutex. And she 1 week ago, about 10, 12 days ago, delivered an 8-pound, 1-ounce baby girl that stayed in the Eat, Sleep, and Console program of the Children's Hospital at Atrium Northeast, and was discharged with mom. Mom, baby, husband are all together. She's like glowing like a fluorescent light when she comes in, talking about her baby. I was upset with her on Monday because I said, how come you didn't bring your baby? She promises she's going to bring her baby the next visit. And I mean, right before our eyes, we saw a woman go from a pretty destitute lifestyle where heroin was kind of a daily ordeal with her, and pursuing drugs was the thing that kept her, or energized more than anything, to finding out she was pregnant, hoping beyond hope in her own estimation that she could have a healthy baby, and then getting referred from a very, very conscientious ER doctor who was able to call me and start that process. And now we've got a family. We've got a baby that didn't even need, opium or morphine post delivery because in the Eat, Sleep, Console program, moms swaddle those babies, breastfeed those babies. She's still breastfeeding the baby, and do it in a warm, quiet, dark environment. So the babies are basically unstimulated and therefore less apt to go into agitation as they're going through their withdrawal. And son of a gun, we got a family here. It's a productive family. He's working full time. She wants to go back to work in 6 months. And from a heroin using, unattached woman living day to day, we've got a family. I mean, and it's an example of the low hanging fruit in this population, and how we can really create an absolute assault on the opioid epidemic if we pay attention to this population. I mean, I can't predict how this family is going to turn out or whether this baby is going to be wonderful or whatever, but I can tell you, based upon the facts, that child would have a predictive possibility for a normal life at a much higher level than if it had been born, just to mom, was fighting for custody, unattached to the father of the baby, and struggling on a day-to-day basis to get her baby and get her drug. So these kind of success stories are not, pie in the sky, but we've got to, across the country, I think, really pay attention to these pregnant women who are suffering a chronic disease that parallels things like diabetes, asthma, hypertension. We got services for all those chronic diseases, and they have a relapse rate or a rate where they don't take what their medical plan indicates of 40, 50, even 60%. And it's the same for these women who are addicted to substances. We've got to treat them aggressively. And the other thing I think it's really important, because we throw a lot of social service specialists at these people, a lot of behavioral health specialists, even addiction medicine specialists, and in some cases pain management specialists. And you start thinking, what kind of a bill is being run up by this whole process? Well, the medical literature right away refutes any concern about the bill, because I've seen from anywhere from $12, you save $12 for every dollar spent on treating mom, to saving $37 and multiple estimates in between there for every dollar spent. When you factor in criminal justice costs, lost productivity, healthcare, all these things, it's really very cheap to treat mom for recovery, to recover in her pregnancy, leveraging her pregnancy for that recovery in the hopes of getting a healthy full-term baby. So you can't argue from a fiscally irresponsible perspective on these ladies.
We've got about 10 minutes left in our presentation, and I just want to acknowledge the comments in the chat box. Thank you so much. There are a lot of valuable resources that were typed in, so I encourage you to take a look at those, as well as some ability to contact folks for training.